Welcome back, everyone, to session two, from nice to have to need to have, the evolving role of strategic partnerships for critical access hospitals. Across rural healthcare, financial pressure, workforce shortages, operational complexity, and reimbursement challenges continue to accelerate. As a result, many healthcare organizations are reevaluating how strategic partnerships, affiliations, and collaborative network models can support long term sustainability while maintaining local governance and community alignment. In this session, Zach Diargon, consultant at Stroudwater Associates and CEO of the Eastern Plains Healthcare Consortium, will explore how rural hospitals are approaching partnerships as a core strategic priority rather than an operational collaboration model. Drawing from real world examples and network experience, Zach will discuss how partnership structures can support shared services, workforce development, payer strategy, advocacy, specialty care access, and operational resilience across rural communities. Zach, I can see your screen perfectly, and I'm handing it over to you.
Excellent. Thank you, Amy, and thanks to Stroudwater Associates for having me here today, as well as all of you for attending our session. I'm really grateful. Once again, Amy, thanks for the introduction. I am Zach Diargon, um, and I am sitting in a hotel room in Washington, D.C., actually, getting ready. As soon as I'm done here today, I'm headed downstairs for a meeting with Tom Morris and Brock Slaybaugh with NRHA and the Federal Office of Rural Health Policy on a full day, 2 day session about taking rural health networks into the future. So it's timely, and I think a trend that we're really starting to see in DC and throughout the nation is that truly these rural health networks that I'm going to talk to you a little bit about today, just as one model, are growing and gaining steam as a not just a nice to have, but a need to have from several critical access hospitals that if they're independent, want to maintain their independent, or if they have different models, certainly want to maintain their stability. And rural health networks have a significant opportunity in that. So, as you can tell, the title is intentional there. Uh, we're not saying that every critical access hospital, listening today needs to be a part of a rural health network or needs to be a part of a clinically integrated network or needs to be a part of a larger healthcare system. Um, we're arguing something, that's uncomfortable, but I think it's an uncomfortable reality we're all familiar with, is that, the operating environment that has allowed um, independence for critical access hospitals to be there is kind of deteriorating. The pressures that are coming at us now here in June of 2026 are accelerating faster than most individual hospitals can absorb. So in that environment, our argument, our articulation is that structured collaboration is really, really important as we head into the new frontier. You guys know rural. Your CFOs dealing with liquidity issues and significant expense management concerns. Your CEOs trying to figure out how do we negotiate payer and having leverage in a payer environment that's becoming trickier. Your board chairs that are uh, your hospital feels like is on the line on a day-to-day basis from a local government standpoint. So this isn't really about a rural healthcare 101. I'll get into again, articulating kind of the math of why healthcare has changed a little bit in the rural space, but I won't spend too much time on that and really spend a little bit more time as to, what are some of these models look like. Um, the I have a pretty lean, mean presentation. I think there's a whole 8 or 9 slides or so. Um, so I encourage you all to chat in questions. Amy, I believe is keeping an eye um, on the chat and will interrupt me with any questions that are timely. Um, but my goal really is for you all to kind of leave this presentation thinking about what this could look like for your hospital, or what this could look like for your network or for your CIN if you're a part of something like that. Because much like your hospitals, we always hear the phrase, if you've seen one critical access hospital, you've seen one. If you've seen one rural health network, you've seen one. So kind of what I'm going to articulate today, and I'm going to walk through a little bit of the EPHC story here towards the end. That stands for the Eastern Plains Healthcare Consortium. a network of 15 independent rural frontier critical access hospitals that have aggregated to kind of create some scale. That's just one example. What works for us on the Eastern Plains of Colorado isn't going to work for many of you in another state. So it's really an opportunity to start thinking through some things. Um, all right. So the math, I've mentioned the math. I'll fly through this pretty quickly. The One Big Beautiful Bill Act, HR 1, we're aware of kind of the risks associated with that. It's changing the Medicaid trajectory in many of our states. Medicare sequestration continues to erode Medicare cost coverage. Rural hospital transformation program for some of us are real dollars and real opportunities, and for some states, feels like monopoly money. We're not sure how many dollars are actually going to get trickled down to the actual rural healthcare providers. Medicare Advantage penetration, I know a lot of us are feeling that, especially in the south western part of the country, and we're starting to see that creep out west in a significant way. Um, it's really rewriting payer dynamics. Even in rural markets where Medicare Advantage was historically modest, like I said, that trend line is picking up steam from a regulatory burden standpoint, from an administrative burden standpoint, and from a simple denials management perspective. These things are all really tricky at the moment, and which further leads into the challenges of negotiating uh, asymmetry or inconsistencies, at least against Medicare Advantage plans, is felt among all of us here on the call. Private payer leverage is a significant crisis. I know for us on the Eastern Plains of Colorado, our commercial reimbursement relative to Medicare is 149% of Medicare. You look at that compared to the hospitals in Denver, and they're at 240% of Medicare. So over 100 percentage basis points difference simply because we don't have the leverage from that payer standpoint. And some antitrust laws make it very difficult for us as a group to collaborate together. So how are we going to impact the private payer environment, leveraging transparency data to push back in an effective way? Workforce maybe is the biggest headache that a lot of us experience, not just nurses but medical staff as well. But it's a significant structural issue. Executive succession is also a significant problem in provider recruitment, especially in smaller communities with only one hospital. Capital constraints, significant increase in expenses with deteriorating reimbursement. And with the One Big Beautiful Bill Act, should that hit the way we expect it to come 2027, we're going to see fewer individuals in a lot of our rural communities actually enrolled in Medicaid. So our expenses are going to continue to increase, and our reimbursement floor is kind of crumbling a little bit beneath us. So the key point here is none of this is new, right? A lot of this has been happening and percolating for some time. The point is that I think we're seeing this convergence of all of them hitting at once, right? It's simultaneous, it's structural, it's legislative in many ways. Then our historical playbook of let's run a lean hospital, we're going to fight for grants, we're going to manage our cash on a week by week kind of finite basis. It's still important, it still helps, but the question is that something that's sustainable long term? And we argue no. If no single hospital can really address every single one of these six buckets alone, what is their strategic response? And that's where some of this network kind of comes in. So the strategic question has changed. This is really kind of a conceptual reset, I think, for a lot of us. And many of us on the call have begun this transition. Some of us are far into this transition. Some of us are just now starting to think about it. Not a week goes by where I don't speak to a hospital that's interested in standing up some sort of collaborative, whether it's with 3 hospitals or 6 hospitals or 30 hospitals. Because individual hospitals are starting to understand that if we want to compete, if we want to survive, we need to collaborate in a way that we haven't been comfortable doing before. So, for decades, that implicit strategy for many of our rural hospitals was let's stay independent, and we're going to stay independent by being self-contained. That really worked for a long time when payers were a little bit less consolidated, technology was simpler, cyber risk wasn't as significant. We had a stronger population dynamics, our workforce was local, and the capital expectations were lower, right? In a post-COVID world where our expenses have skyrocketed and continue to do so, that operating environment has really shifted. And the new framing is uncomfortable when we're having these talks with these new boards and these hospitals that are exploring it. the new framing really is the argument that if you want to stay independent, you have to do that by being deeply collaborative. You can no longer just operate within the four walls of your hospital to succeed for most of us in a critical access environment. And we argue that the hospital is most likely to remain locally governed with your local board of directors long term are the ones that are most willing to do the hard work of structured collaboration with other healthcare providers outside of the four walls of your hospital. Um, so I think it's important to articulate that independence and collaboration are not opposites. You can maintain your independence while still collaborating with a hospital 35 miles away from you where it makes sense. Um, Independence is not isolation. And as you'll see from a slide from what we're doing in Eastern Colorado, how can we start to act like a system without becoming one? And that's a tricky thing. It's a tricky balance, but there's a lot of benefits to it. And finally, how can we create scale without consolidation? A lot of the value of what a rural health network can do is aggregating multiple hospitals, multiple providers, multiple executives together to generate some version of scale like a system would, without consolidating under one single tax ID or one single operating structure. So these are kind of governance commitments to think about as you kind of dip your toe in the water of partnering with a rural specific organization. Um, some hospitals are not operationally ready for that true strategic collaboration. Um, and I think there's probably some of us on these calls saying, I'm a part of a rural health network and I'm not getting anything out of it. The question I would challenge you with is are we just attending the meetings and expecting the rural health network to generate some value for me, or are we engaged in the meeting and are we actually bringing a collaborative mindset to it? Some of the work of collaboration is failing to collaborate and learning why. The next slide well, maybe it's in a couple slides, talk you through kind of the the genesis of how a rural health network gets started and the importance of that communication and that trust and how far that can get us as an organization. So if the new question is what is the collaborative infrastructure we want to tackle, we have to start thinking about what we want it to look like. So this is really kind of the central concept, so to speak, for the rest of my talk here for the next 15 or 20 minutes or so. Um, and so you can see the spectrum of one all the way to six. And in reality, this line would kind of wiggle and waggle a little bit and look more like a highway through the mountains than it does a straight line, just because everything does look a little bit differently. But this is a opportunity for us to kind of take a step back and think about where we are. And when I get to the end of this poll, end of this slide, I think we have a poll to launch just to do a quick pulse check of an assessment. But I'll walk through that and then we'll launch the poll. Positions 1 and 2, the informal peer networks, group purchasing, and shared services. And it's worth articulating. Position 1 or 2 are not lower quality collaboration for many critical access hospitals. An informal peer network or shared services is exactly the right level of structure for where they are operationally. So informal peer networks, what that means is, hey, we're going to get our 6 hospital quality directors together or our HR together and have some meetings, have some conversations, whether they're structured or unstructured, and let's support one another and see what kind of pops out of that. Create some shared learning opportunities. That's something that can bring a lot of value and a lot of collaboration together and create some scale organically. That doesn't require a ton of governance, doesn't require a ton of investment, but it can take somebody in a department of 1 and make them feel like they're in a department of 6 all of a sudden. We always say our HR directors, our quality directors, our infection prevention leaders, they're probably the one person in the county, especially in a frontier environment like ours in Colorado, the one person in the county doing their job. So the CEO at the hospital or the CFO at the hospital might not know what's going on a day-to-day basis with that quality director, but guess who does? The quality director an hour away, in the next frontier county. So creating that kind of informal seed can grow into some unique things. Group purchasing and shared services. This is where we can take the scale of multiple hospitals together to partner on with a specific GPO to drive down the cost of the equipment or the supply chain purchases that we're having to work. Can we share staffing in a unique way, whether that be nursing staffing or medical staffing? Um, and moving into number three is really where we can move into formal healthcare networks. I think you can generally get through the first two, number one and two, without a formal structure, but where what a formal rural health network means is where governance lives, right? So we have a formal entity established. In the case of EPHC, it's a 501(c)(3) organization, where governance, you have a governance structure with a board of directors deciding what is the directive of this rural health network. You have fiduciary discipline, you have a treasurer, and you have multi-domain shared infrastructure live. Where EPHC is a member of an organization called the National Cooperative of Health Networks. And this is what a lot of NCHN, National Cooperative Health Networks, look like. We are an organization that really acts like a state hospital association, but the reason a lot of rural health networks got established is because our state hospital associations are pulled into a lot of different directions, right? There's a lot of politics at play of we need to make sure that we're not just representing our rural hospitals, but we're also representing the large tertiary urban hospitals, and some of the decision making and some of the governance can be split, right? So the establishment of your own rural health network, where you have an individual at an executive level waking up thinking only about your rural environment, can be a really impactful thing from a scalable perspective. Position number four is specialty and system partnerships. They often coexist with networks. And again, there's a Venn diagram here of all of these things where they can mix and match together. Um, and it's not necessarily a replacement, but do we as a group of hospitals, are we aligning on a service line strategy? Are we aligning with a singular telehealth organization to drive down the cost and align the operational impact and improvement? Do we have transfer relationships? Are we working on GME or rural residency programs in which we are able to bring in uh, recent med students who are in their rural residency programs to rotate at multiple of our hospitals, because a singular one of our hospitals is not going to have a strong enough volume to maintain or retain a rural resident. But if we can collate and have three or four hospitals together, we might be effective in doing something like that. Position five, I've got a whole slide on it. CINs and ACOs, that's the sexy talk right now. It's If we boil it down, as you can see on the slide here, it's the contracting and a quality vehicle. It requires significant operational readiness. It may or may not be appropriate depending upon your payer mix or Medicare Advantage penetration, state policy, value-based readiness. I'll go into it a little bit on the next slide, and I think a lot of us, and I know we have talks on it here with the Stroudwater CAH conference, and we're talking about it downstairs later. The federal government, and I know many of your states, are really pushing clinically integrated networks and accountable care organizations, especially tied to the rural health transformation funding buckets in a significant way. So there's big opportunity here. But as we've seen over the last 5, 7, 10 years, it's not an easy thing to execute on. So if you were really going to make that migration from rural health network into clinically integrated network, there's a lot of overlap there. But the CIN requires a significant level of alignment with the peers surrounding your own individual hospital. Finally, position six is acquisition or consolidation. It really represents represents full integration, right? A deliberate choice for your facility to give up your independence governance. For some hospitals, that's the right answer, right? Especially hospitals in environments where sustainability is impossible without the support of that system. Systems can certainly bring a lot of really good value to a rural community. So we don't assume that everybody in here certainly wants to stay independent, and that's absolutely the right decision for some people. But that's what full integration might look like. So, and I'll say again before we open up the poll, more structure here does not mean more virtuous, doesn't mean it's better. Each model fits different geographies, governance maturity, payer environments, state policy context, what your board of director wants, what your community wants. As we all know, and we're experiencing with our HTP, rural healthcare does not lend itself to one size fits all solutions. So it's important that you be weary of any consultant, including Stroudwater Associates, offer you a single answer for here's the best thing to do, because that doesn't necessarily exist. All of you need to decide what makes the most sense for your organization. And with that, we'll launch our poll question. Hopefully that goes smoothly. So the question we want for you, and this is just some real time data for us is as you think about your critical access hospital, most meaningful structured collaboration with surrounding rural hospitals today, where would you put yourself on this spectrum if you had to pick if you had to pick one of these buckets? I know I just spent 10 minutes telling you there's no necessarily one bucket, but um, all right, we're getting mixed response here. Amy, I don't know if they can see the results or if only you and I can. We still have some results coming in, so we'll hesitate while they come in. Um, it about 21% of us, we have 13 out of 62 respondents said that we are in bucket number one, informal peer networks only, meaning we share knowledge with no formal infrastructure. 12 of us said we're shared services or group purchasing. 12 of us are actively participating in a CIN or ACO or other value-based contracting structure. That's great. 8 of us are a rural health network member. 8 of us are partnering on specialty or systems. This is good. So we have a really good mix of folks here today of where we stand. So um, again, there's no right or wrong bucket for where you need to be. And if you walk out of this um, presentation today saying I think we're comfortable with where we are, that's certainly an okay place to be. So thank you guys for filling out that poll for us. Um, I want to take another minute on CINs, just because we have such a provocative moment in time with clinically integrated networks. We had our network leader conference. There's probably about 35 of me in the country that are running a rural health network, and we have a conference once a year. And just about every topic came down to these CINs because of, as I've said, it's really where the so much of the federal policy is pushing rural hospitals, because rural hospitals with our population dynamics, it makes sense that if we are going to see an actual shift in healthcare payment system, that in a rural setting that probably needs to be on the outpatient side of the house. We are already positioned effectively. The outpatient clinic is the front door of our hospital. So I think the question that the federal government and many of our states governments are asking is, how do we make the front door of your hospital the community, and be more effective in proactively engaging that patient population before they have to walk into your emergency department, right? Um, all of you, I promise, if you're not a part of a CIN, have been pitched a CIN as the answer over the last year or so. Um, and really over the last 7 years, it's been a model that's been around for a little while. Some of those SINs have seen success. Many have been extremely disappointing. Um, I think the reason for disappointment is almost always the same, and I alluded to on the last slide, the underlying network, right? Do we have strong governance? Do we have good trust among the organizations that are going to be formulating this singular entity? And do we have good shared infrastructure? If we don't have those three things, that governance, that trust, and the shared infrastructure, uh, you don't have a SIN. You're not going to have an effective SIN. So um, rural health networks are not new. In CHN, organizations like Eastern Plains Healthcare Consortium, Western Healthcare Alliance, Montana Health Network, Torchdown in Texas have been doing these works for decades. Um, and longstanding rural cooperative statewide alliances predate SINs by over 20 years. The Rural Collaborative up in Washington is doing some really unique things, impacting the payer environment and their denials management program without having to get into a clinically integrated network environment. So it's okay to say SINs are not for us, but it's something that you have to keep kind of exploring, as we do suspect that future grant dollars are going to continue to be tied to SINs. But the message here is that a SIN without a network um, is a legal entity, and a network without a SIN is still a network. So a network can still exist with shared services, with advocacy, workforce collaboration, peer learning, payer data. A SIN can't necessarily provide those things for you. So there's a little bit of a Venn diagram of a natural um, pathway from a rural health network is to evolve into a clinically integrated network. And that's what EPHC is getting ready to do over the next couple of years or so. The most common failure mode of hospitals, and we hear this from a lot of consultant firms offering to stand up um, one size fit all clinically integrated networks, is to chase value-based contracts straight out of the gate. We hear a lot of from rural hospitals, hey, we're going to join this SIN, and then we as a group of 15 hospitals are going to go negotiate a private payer rate. Cool. That's an awesome idea. And it is theoretically possible. Um, but that's a really, really challenging, that's gold at the end of the rainbow, and you have to build a lot of rainbow before you get there. So if you are going to develop a SIN with that end goal in mind of, hey, we're going to take X hospitals and try and negotiate a rate, let alone negotiate an effective value-based contract, you need to make sure that you have developed that governance discipline, data infrastructure, care coordination capacity. You need to ask the question: do I even trust the hospital in the next county to deliver on what we're aiming to do? So networks who build trusts over some time across multiple domains, develop shared services, and then move into clinically integrated network, we see some more success in. No, not everybody has that luxury, right? With the environment, some of us are going to have to dive into this. If that's where you sit of, hey, we know we need to get into a CIN because X bucket of dollars are in it, and we think philosophically it's the right thing to do for our patients and our communities, great. Start with governance. How do you make sure that governance decision is still being retained at the local hospital level? Is a significant priority. So they're useful in specific market contexts, especially where Medicare Advantage penetration is high and state policy rewards integrated contracting. Um, but SINs in and of themselves are not necessarily a strategy. They're a vehicle to achieving a strategy. So a vehicle without direction or without fuel, without the driver is not really going to get you anywhere. So you can't just stand up the SIN. You have to understand what you're trying to achieve with that SIN. That was probably too much time on clinic integrated networks, but we get those questions a lot. All right, so how do networks get built? This is kind of the basic operational backbone slide of the presentation. Of if we wanted to start, and I know about 21% of us wanted to start here. Of how do we start? I think this is a generally good high level opportunity of how you can start partnering with other organizations surrounding your hospital. So stage one, affinity and trust. It's the most underestimated stage. It's the unglamorous, super slow, easy to skip stage because we're all super eager to get to stage 2 and 3 because that's where I want to drive down costs for my GPO or something like that. Um, it really looks like collaboration, right? Are our CEOs candidly discussing their succession risk? Are they talking about the risks to the bottom line of their hospitals? Are CNOs sharing their recruitment best practices and collaborating? It in this early stage, it really can feel informal because a lot of it is, right? If we can get our nurses together, if we can get our operators together, if we have ORs, we can get our surgical directors together and start having conversations about our pain points. That's where trust can develop, and that's where alignment can develop, and understand that the problems I'm experiencing in my county are the same problems that you're experiencing in our hospitals, or some have us share enough similar DNA that maybe the two of us, the three of us, can tackle something together that I can't do on my own. Um, Networks that skip that stage, and you're allowed to do that stage. You're allowed to collaborate as long as you're not jointly negotiating a contract or you're not, sharing employee compensation data. You're allowed to do that. You're allowed to create those relationships. But we know that networks that kind of skip that stage usually end within a year or a couple of years. Stage 2 is structure and governance, right? This is where it's that next step, and it's where many networks can stall, right? This because we move from like the really exciting kind of unstructured to the unsexy work of structure of establishing bylaws, of establishing membership agreements, dues structure, board composition, fiduciary, treasury clarity, conflict of interest policies, and hopefully a dedicated leader, right? We argue that a dedicated leader over the network is important. all of you as executives in your hospital or board members, you wake up thinking about your hospital. Naturally, if you wake up thinking about your hospital, no one's waking up thinking about this new network you just developed. Do we have a plan in year one or two or three to bring in our own, even if it's a part-time executive director who wakes up every day thinking about your network, can bring a lot of value. And really making that commitment that governance is not just a meeting. We need to make that shift from stage one to stage two of it's great when all of us CEOs get together and have that affinity conversation about here's how difficult the environment is right now, or what are you doing, or how did your joint commission survey go, or how did your I heard you had an Intala violation. What was that like? That's all extremely valuable and oftentimes the most valuable thing a rural health networks has. But moving from how do we move from that meeting to an actual board governance meeting is a discipline. And that's really tricky. And that's where a lot of rural health networks can fall apart because we get so much value out of that stage one. We can't forget that we have to actually operationalize this larger structure. So a lot of collaborations fail at this stage, not because the structure was wrong, but because the discipline was insufficient. And when we have a board of directors, like in the case of EPHC, who are all rural health CEOs, we really want to spend time in bucket one talking about how difficult some of the challenges are. That when we move into a formal board meeting of bucket number two, um, we don't actually do the actual governance work we need to do to sustain our organization. Stage three, shared capabilities. This is where we've established the trust and kind of the commiseration of stage one. We have a good structure. We actually have an entity. Now we can start doing some of the really fun and exciting things, right? This is where members start to feel the network and their P&L, right? Group purchasing, advocacy at the state and federal level. Maybe we're sharing IT and cybersecurity workforce, um, payer data aggregation. These are the deliverables that justify the dues line item, right? We've established a dues structure in stage two and where we want those dues to go. Maybe half of it is paying for the executive director, and the other half is the executive director is using those dues to invest in some of these aligned strategies that are then passed through to benefit the hospital that we individually can't do. So that's where, in the next couple slides, I have a brief overview of what EPHC is working on. Like a shared services portfolio, right? Our network has discounts for our 15 hospitals for group purchasing, payer transparency data, underpayment recovery, executive recruitment, IT staffing, governance, education. All of that really lives in this stage. And then finally, stage four is strategic alignment. This is where appropriate, our hospitals adopt one of the key pillars of Stroudwater Associates of interdependence, where networks start acting as a unit. Yes, we all as individual hospitals need to be independent, but how are we leaning upon one of each other to raise the tide of all boats? Um, that can be things like payer strategy coordination, not on negotiating a rate that's illegal, but in some states we're allowed to talk about denials management directly with a payer or talk about prior authorization best practices, working towards value-based readiness together as a group, regional referral and transfer alignment, possible clinically integrated network exploration. And it's important to note, again, just like the previous slide or two, stage four is not necessarily a destination every network needs to reach. Some networks are most valuable as a strong stage three entity, right? So stage four, for a group like ours, where we have 15 hospitals that are all in the old, poor, sick, rural frontier part of the state, they're all critical access hospitals that are so similar. Makes a lot of sense for an EPHC to bring strategic alignment for a statewide or a multi-state network like Montana or Western Healthcare Alliance or Torch. It can be challenging to find true network-wide strategic alignment because the DNA of your hospital is so different. So you don't always have to start with stage four being the end goal because maybe stage three is a good end goal and we've aggregated enough hospitals together to drive down costs and truly just negotiate or advocate in an effective way that's enough for our hospitals. And that's where board governance can come in, and helping with that decision making to support your executive director and the decisions that they're making. So I think the key warning here is skipping stage one or skipping stage two to try to get to stage three is really the most common cause of collapse. You guys you're going to have consultants or vendors showing up to a new young network proposing a clinically integrated network, and promising that you're going to be able to negotiate with an Anthem or a United in day one. Um, it's that's effectively asking all of you to jump from stage one to stage four without some of the supporting infrastructure. So just make sure when you make some of those large swing decisions that you understand where you are in this stage kind of lifeline. Um, Shared services. Here are just some examples. I'll fly through this really quick and spend most of the time on the EPHC example, but these are just some answers of what could collaboration actually do for you. So we know workforce, it is maybe the single largest operating risk for most critical access hospitals, other than revenue cycle and good understanding of critical access finance. But networks can let members access executive search opportunities, residency pipelines, retention programs, and norms. One of the biggest things EPHC has done is start to establish the norms against intra hospital kind of talent coaching, right? Because that's a really tricky thing. How do we stop the escalation of rising expenses and stealing from one another by having some of those uncomfortable conversations? Um, Payer strategy and data, shared services, purchasing, advocacy, care coordination. Now that I'm looking at my slide, I think I'm going to just move to the next slide to give you some more concrete examples of uh, kind of what this looks like in practice for my day job with the Eastern Plains Healthcare Consortium, to crystallize it. And again, the framing here matters. This is not, hey, here's how you do it. This is how one frontier network is attempting to respond to those 10 buckets I showed you on slide number one, and what we're wrestling with and how we're trying to tackle it. So again, we have 15 hospitals. Almost all of these are frontier counties. Um, Almost all of them are critical access. One of them is not a critical access hospital, but is pursuing that designation. Um, and we've bucketed our strategic plan into two large buckets at the network level. And I guess we're saying EPHC, we're 11 years old now. These hospitals have gotten to know each other. We are amidst the transition from stage three to stage four of truly aligning our strategies together. Because as you can see, when we are all so similar, EPHC is able to create strategies at a higher level that are able to with a broad brushstroke impact all 15 of our hospitals with one strategy together. So I won't sit here and say we're the best rural health network in the country. That's where we want to be. That's our goal and our effort. Um, and we feel lucky. I often tell my peers throughout the country, my job's easier than a lot of other network peers because our hospitals are so similar. We're very cautious about what hospitals we bring into our network, because if we were to bring in non-critical access hospitals or venture out into another state, it changes our DNA in a different way that we need to be very, very cautious of. And does bringing in a new member, maybe a member on the Western Slope or in New Mexico, does that change our DNA so much that it threatens that stage four of actually being strategically integrated as a group of hospitals? So our strategies is two things, two pillars: grow volumes at our EPHC member hospitals and improve payment. And we're doing that in a few different ways. Um, Number one, data investment. We've partnered with our state hospital association to negotiate access to the CHA, Colorado Hospital Association data, on behalf of all of our members to help with our retention volumes, right? Every single one of these counties on the slide, our population is deteriorating, with the exception of 65 plus. And I think that's probably true of most of us on the call here. So we're not magically trying to grow our volumes and bring more people into our ERs, but it's a retention opportunity. So if EPHC can play that data role, kind of that business development role for our hospitals, and say, hey, Sedgwick County Hospital, do you know how many cardiac medical patients are leaving your hospital and why? And really kind of give them the answers to the test of what they need to be recruiting, we're going to be more effective in retaining. Swing bed optimization, we're partnered with an organization to help us with our revenue cycle functions around swing bed. Um, engaging with the larger healthcare systems in the metropolitan areas to make sure that when Zach is transferred to Denver, when it's time for Zach to go to rehabilitation that is swing bed eligible, let's ship him back to the Eastern Plains as opposed to moving them upstairs to the floor and keeping them within the system. We've established more formal case management and swing bed affinity groups. That's our stage one of that group of let's make sure we're supporting our case managers and our swing bed leaders in our hospitals and identifying best practices in alignment with that swing bed optimization. We've announced a new rural residency program with the University of Northern Colorado School of Doctor of Osteopathic Medical Program. We're going to have, starting in 2029, 4 rural residents rotating in our hospitals, and we're going to be adding 2 a year until we have 12. So in a half a decade or so, we will have 12 rural residents rotating in all of our hospitals, all with the goal of trying to address the primary care physician shortage pipeline forthcoming. We do a lot of policy and advocacy work. Many of you have probably heard about our Rural Hospital Revitalization Act efforts as a mechanism to expand the eligibility criteria for large capital grants from USDA to establish new hospital builds. And we're really we're exploring partnerships with third-party vendors as well as large healthcare systems to see, can we lease and stand up our own transfer center? The biggest operational opportunity for us to grow our volumes is making it easy for our medical staff to refer to a sister EPHC hospital. Right now, if I want to send to an EPHC sister hospital, I have to call around and see if the general surgeon's on call this week, and if they're there, great. When I have conversations with our hospitals, they always say, I'm happy to send to hospital X, Zach, but right now it's not easy. So if we can get to the point where we have one phone number to call that's representative of all EPHC, our medical staff is articulating, we're happy to do that. We'd rather keep the patients on the plane than send them all the way to Colorado Springs or Denver just to bring them back. So those are some examples of how we're shifting into this strategic standpoint. From the payer environment, EPHC took some of our membership dues and some of our earnings from our shared services programs to buy payer transparency data for all of our hospitals and to partner with a vendor who is going to do underpayment recovery for all of our hospitals to impact our bottom line. And it's something that the board of directors was a huge priority. We know we need to start getting paid better due to our lack of negotiating power. And that's just a very cool offering and deliverable that we get to walk into the CFO's office and say, here's all of the transparency data for the state. So next time you're negotiating with United, you can get down to the CPT or down to the DRG level, identify how much you're getting, what rate they're offering you, and you can compare that with every hospital in the Eastern Plains, every hospital in Denver, every hospital on the Western Slope, so that you have a little bit more teeth in that uncomfortable negotiation. EPHC does have a partnership with Stroudwater Associates to do cost report reviews, and we've, similar to swing bed and case management, we set up our finance and revenue cycle affinity groups. We do a very heavily didactic blocking and tackling. We truly believe that all of our hospitals need to have a good understanding of critical access finance, revenue cycle at the front, mid, and back end. So we've really been focusing on that. And then finally, we are embarking, come January of next year, embarking on a statewide clinically integrated network in partnership with our counterpart network on the Western Slope of Colorado, the Western Healthcare Alliance. So we are in the enrollment period here in the final week. We'll have probably half of our members or so engaging with the larger entity on the Western Slope from an accountable care organization standpoint and investing in this statewide clinically integrated network. And we're pursuing RHTP funds from Colorado to help stand that up. Last couple slides here, and we'll see if we have a little bit of time for me to get through some questions at the end. This is the this is the caution, right? I say this as a guy who grew up in a larger healthcare system. Healthcare systems are not inherently good, bad, or ugly. I think all of us here on this call engage with at least one regional or tertiary system, whether that's through a transfer relationship, telemedicine, GME, service line support. So systems aren't bad. That's the wrong debate. It's how do we leverage them what are we leveraging them for, and how do we make sure that we're protecting protecting our independence and our governance as we do so. So the things that we see strong health networks partnering with larger systems for are things like specialty access, traveling specialty providers, traveling surgical providers, transfer pathways is kind of the easiest entry point that most of our hospitals partner with. Telehealth, especially in the emergency department, things like hospitalist services, telebehavioral health services are increasingly becoming the norm of partnering with larger healthcare systems. Most healthcare systems have telehealth that you can leverage in your emergency department or telepsychiatry services that you can leverage in your emergency department. So the decision is which partner and on what terms do you want to do that with. There are good telehealth organizations out there and there are poor telehealth organizations out there. The big question that you need to be asking is what are you doing to help me retain patients for every service line except behavioral health or psychiatry? For that question is what are you doing to help me get this patient to the next level of care as quickly as possible and as safely as possible? If your system can't answer those questions effectively or can't bring data to you to prove that they're doing that, there are certainly telehealth organizations out there that can do that. GME workforce, that's kind of a longer tail investment, but one that can be strategically important. Rural residency partnerships are multi-year, right? In the case of EPHC, we're having to partner with HCA Health One in our market as our sponsoring institution, simply because we don't have enough pediatric or labor and delivery volume. So 49% of our rural residency volume, most of that is going to be labor and delivery and pediatric in the city. But in order for us to establish that rural residency program, we needed that large partnership to get this thing off the ground. So that's a good example of, and we're going through the governance process of how do we make sure come 2029 we're actually hitting those measures together. IT and cybersecurity, something I wouldn't underestimate right now. A lot of systems can offer really very real cyber security support, as well as EMRs. We all know we need to be cautious with things like that. But especially in the world of artificial intelligence and its denials management program, we're already starting to see systems say, "Hey, we've built this AI program and denials revenue cycle program that's bigger than all of your hospitals combined, and we think we could carve that out for you at a reasonable rate. Are you interested?" Those are things we need to start thinking about. And then capital partnerships, you have to be extremely very careful from a joint venture standpoint and explicit governance boundaries. I think that the messages here is how do you partner without getting married? So from the protecting side, just worth re-articulating. Governance and board authority are non-negotiable. If any partner requires you to surrender any meaningful decision rights over community impacting questions, it's not a partnership. It's a step toward consolidation, towards that last stage. You need to be wary of partnership structures that quietly substitute for your local financial accountability. You need to maintain your brand and identity, right? Local trust is not transferable. The brand a system can give you is not the brand that you already have in your community. So you need to understand that your brand carries power and that your community certainly views that brand, hopefully in a positive light. You need affiliation flexibility, especially like in a telehealth world. If you have organizations that are offering you an orthopedic surgeon or a telepsychiatry program and saying, hey, you have, as a result of signing this, you have to be exclusive with us for all of your telehealth services, for all of your outpatient surgical services, that's no longer the way of doing business. We as critical access hospitals we need to be able to put our puzzle together. And that means having a telehealth program or an outpatient surgical specialty program that is made up of multiple different system-based vendors and non-system-based vendors to create something good, just because not everybody's good at everything. And so if you have organizations holding you to exclusivity clauses, that is an old operational reality that no longer exists. Which leads to this last bullet point here, the right to walk away, right? Every well-designed partnership needs to have very explicit off-ramps for you. If you cannot exit, then you don't have a partnership. You have an acquisition with extra steps that you're heading to. So 4 questions we always have hospitals ask for their entering into any system level partnership. Number 1, what does this solve that we could not solve alone or could not solve through our rural health network? Number 2, what decisions do we retain and what decisions do we share? Number 3, what are the exit conditions and renegotiation triggers? And number 4, if this partnership fails or ends, Are we operationally and reputationally whole? Finally, last slide. This is the closing slide. We'll have a couple minutes. I went a little longer than I thought I would. Collaboration is governance work, not marketing work, not vendor sourcing, um, not a logo on a brochure. The discipline of structured collaboration is the same discipline that makes any rural hospital well governed in the first place, right? Clarity, accountability, and that's really what I want to leave you with. Of as you venture into, I know a lot about half of us were exploring wanting to stand up a rural network. If that's what you're doing, um, networks don't fail because of bad strategy. Strategy is not the hard part. Anybody can develop a strategy. Networks fail because they have the poor governance and unclear authority. So with that, I'll stop and pause here just in the last 5 minutes if there um, are any questions. I think now is the time, Amy.
Yes,
If we have
at this time, if you have any questions, feel free to go ahead and put them in the Q&A box, and then we will get those answered. And I believe one question that did come in is what factors should we consider when deciding between partnering with a large health system versus creating our own collaborative network with peer hospitals? Are there any factors that we should consider, Zach?
um, I don't think you need to truly choose one or the other necessarily. I think there's value in exploring both opportunities, and I really think, and I'm not sure what time that question came in, but kind of going back to that governance test of a system, partnering with a large system it can absolutely be the right thing for your organization as long as you're meeting those four kind of criteria, right? What problem am I solving that I couldn't solve alone? What decisions am I retaining and what decisions do I have to share to a larger healthcare system? What are the exit conditions? And if they fail, will I be harmed? Right? If you can answer all four of those pretty comfortably, I think it's okay to pursue partnership with a system. If any of those feel squishy or feel uncomfortable, that's where I think a rural health network might make more sense. And again, I don't think this has to be one or the other, right? For hospitals that are in a rural health network, it doesn't mean you're not going to be partnering with a large system. And in most cases, your rural health network leaders are also going to be partnering with a system in a unique way. So I think it all comes back to what problem are you trying to solve, and um, is there a different way of solving this alone that we feel like we couldn't otherwise do?
Yeah. And so if any of our participants have questions about like how do they get started, is there a step that they should look at? Do you have contact information that you could share? I think it was in your slide deck. Do you want to share your contact information slide?
Um, you know what? I actually don't think I put my contact
All
information.
right. Well, I do know that. So the version of the deck that I have of yours had that information there.
Okay.
So just to know everyone that we will be sharing the decks after this session, and it will have Zach's contact information to reach out to him if you have any questions. But thank you, Zach, for an insightful discussion around the evolving role of these strategic partnerships and rural health networks and how they are supporting rural healthcare. And to the audience, as a reminder, when you exit today's session, you will receive a brief pop up survey. Your feedback helps us to continue shaping the future conference programming and should take less than a minute to complete. If you're joining us for the next session, please return to the conference library, click into that session from the agenda, and we will begin at the top of the hour. Our next session will focus on evidence-based approaches to rural hospital replacement planning and capital investment strategy. So thank you everybody for joining us for Zach's session. Zach, have a great day there in DC, and we will see you all at the top of the hour.
Thank you all.